Welcome to the Honest Psychologist podcast, where two licensed clinical psychologists have joined the chat. I'm Dr. Whitney Graff.
I'm Dr. Paige Hover. We bring our years of expertise to the conversations you're already having, breaking down the topics shaping culture, social media, and everyday life.
No psychobabble, just relatable discussions about how our minds work and why it matters.
Okay, so we were just talking about this post hoc way of diagnosing or thinking through, like, should I get an evaluation?
Yeah. So like if somebody, what I mean by this like post hoc thing is, if you're looking at the characteristics of somebody who's gotten a certain diagnosis, like for example, ADHD, and you're saying, well, people with ADHD all seem to, maybe they lose their train of thought, or they
have difficulty in relationships, they struggle at work.
Oh yeah, these are great ones. Yeah, difficulty in relationships or whatever, or lose a job or something. It's to work backwards from that and say, well, I have those things in common. That's not how diagnosis works.
No.
It's an odd way to go about a clinical diagnosis, to start at the conclusion. So in this example, it was like, well, I've heard that people with ADHD get overwhelmed or they experience emotion dysregulation, and I have all of those things. So then to kind of work backwards and say, well, does that mean I have ADHD? I can understand the impulse, from a layperson, but from a doctor's point of view, like from a clinician standpoint, that would never be how we would approach this. You start with where the problems actually are. Like, show me what is actually giving you trouble. And then we gather more information about those things, try to put them in context. And then we say, which direction is this actually taking us? Because emotion dysregulation, problems concentrating, these are very, very general symptoms of lots of different things, even medical conditions.
For sure.
So then part of the information gathering is, have you had blood work done? Do we know if you have a thyroid condition? It would be very odd to sort of start at the conclusion and then work backwards to the beginning versus to start where you are and then work forwards, gathering the information that would actually be useful.
Right. Like, you're not going to start by assuming you have cancer and then go get the MRI to see if there's a tumor. Like, I think that there would be kind of maybe like, hey, there's these symptoms and one of them could be cancer, but it could be these other things. So let's go to the doctor and say, hey, here's my symptoms. What could this be? Versus like, hey, I'm pretty sure I have cancer. So how do we prove that kind of thing?
Yeah. How do we prove that you have cancer, starting at that end point? Whereas I'm tired all the time, but in my case, some blood work showed some low B12, it's not about saying well, people who have cancer are also tired and I'm tired. That's the backwards way of looking at diagnosing. So it's more likely to say well, gee, Whitney, it seems a little unusual that you should be tired. Let's run some tests and look, you have a level that's kind of low. Could you supplement it and then see if that changes it?
Yeah. I mean, it kind of reminds me of the WebMD way of looking at things, where there's all the information that could be available. And I think when WebMD came on the scene, it was really hard because it gave you all of this information, but you didn't necessarily have the knowledge to understand what that meant. All of the options were there for, hey, I have this bump on my head or I'm tired. Well, it could be 1, 2, 3, 4, 5, 6, 7 different options, but we don't have the knowledge to know how they come to those conclusions. It's just all this information in front of us. We can't discern that. And I think that's a lot of how social media has really played a role in this, because there's a lot of the conclusions leading first, and then people then are identifying with it and saying, oh, well, that must be what I have. So it's kind of the same idea of just the WebMD effect or the social media effect, where there's a lot of information out there, but discerning what that is, I mean, that's kind of our job, but
Yeah, that's supposed to be, again, I don't blame the layperson who's encountering these
Yep.
things. Like if but I do blame fellow clinicians who do the exact same thing, start at the end and work backwards, and don't investigate other possibilities. And maybe I'm grumpy for no reason because referring for assessment is the exact right thing to do.
Right.
So yes. And it's hard, I think it's hard when clinicians, again, I'm empathic to the clinicians as well, because it's like they have a relationship with the person that they're trying to maintain, and they also want to motivate someone to follow through on this recommendation. But I'm saying it's like hard to not get attached to a certain label or a certain outcome before you've done the investigation, no matter what, by kind of suggesting the possibility. And when we don't have a biopsy like they do to investigate cancer, we never have a straight yes or no.
No.
I can't say that tumor is benign.
Yes.
I can't say your concentration problems are benign.
Right.
Because I have no objective lab measure, no test, nothing that will say it. It's all kind of matter of interpretation and opinion.
Yeah.
And so once we've planted the seed that, well, you have this in common with all these other people, how do we expect, an average person not to sort of get, like, that's just our cognitive biases, that we start going, well, if it walks like a duck and quacks like a duck, it must be a duck. Then it's hard to work around that and say, but there's also other things that do this too, because we've already carved this pathway of thought in our mind.
Yep. Yeah. And it's hard, I think, like, even if you go back to the example of cancer, it's like when you think that through, it's kind of shocking sometimes when it's like, no, but I'm pretty sure that was what it was. And sometimes it's a relief, but sometimes it's like, oh, what is it then? Or like if there isn't a clear answer, that can be disappointing too. So I think that there's always this desire for clarification, and I get it. It is frustrating. We don't have a blood test to test for ADHD or autism or anything else, but I do think we have to approach things with a much more open-ended kind of question.
Yes.
Rather than, I think you have ADHD, go get the test to prove it.
Yes, that's exactly the framing that's the problem. And when a professional says that, that is the problem. Yeah. So anybody who calls me will get prompted, like, well, what are the bigger questions beyond a yes or no that you're hoping to answer? And it's still, it's really honestly delightful when people can bring their own curiosity to themselves. And I've said this to clients, I've said it to you, that like undergoing evaluation is incredibly vulnerable and scary. And so, if you can approach it with curiosity, all the better. But I do totally understand, just the bravery that it takes to go in and ask questions about yourself. So I think that's to be respected.
And that might be part of some of it too, is holding on to this one answer, because evaluations are vulnerable and vast. There's a lot of information you can learn. Even if you are just going in to assess for like one condition, there's still more information you're going to learn generally about yourself. And I think that sometimes the idea of maybe holding on to, or like narrowing the focus, helps you get through it. It's like a smaller bite to chew that is like, okay, can you just tell me if it's this, like I can handle that right now. I don't know if I'm ready to know all the other pieces yet.
Oh, that's actually lovely. Thank you. Oh, well, so we just dove right in there because we were in the middle of an interesting discussion, but hello.
Yes. Hello, everybody.
Hello.
Welcome back. But we were talking, the topic for today was if you should get reevaluated.
Yes,
but I think that the general question too we're asking is, when should you get evaluated? Like reevaluated is a question, or when should you get evaluated?
Yeah, exactly. That's our topic. I'm pulling up my notes. Anything interesting happened to you this weekend? No. I had a really good weekend.
Yeah, no, it was pretty quiet. Did a lot of organizing and trying to stay cool, and walked in my old neighborhood, which was so nice, and hit up some old coffee spots, and the dog got to go to all of her places that had dog treats, which is great.
Oh, you know what we came up with this morning was what if there was was it like social media for dogs, or like like wellness influencing for dogs? Because it was like, are you too hot when you're sleeping? Have you tried going into your human's bathroom, knocking off all of the shampoo bottles and climbing into the tub?
Oh, God. Yeah. No.
Bored this weekend? Why not go outside, come in, then ask to go outside again?
Or not sure if you want to go outside? Just ask them to open the door and stick your nose out, but don't actually go outside.
That's right. This is an excellent way to judge the weather.
That's Sierra's favorite thing.
Butt stays warm and your nose gets a breeze.
Yeah.
Hashtag lovely.
Yeah. Okay, so
the question was, I wanted to make sure we said, should you get reevaluated or should your child get reevaluated? Because we may have listeners who've had a child go through a psych evaluation, and so I know we usually test adults, but obviously testing kids is a and I think big industry, for better or worse.
I mean, that's a good kind of, I think that's the most concrete place where the answer would be yes. And that's mostly, I was thinking about accommodations. When we posed this question, I was like, well, when would I say yes? And part of it is if your child or you as an adult have accommodations and want to continue to have accommodations, reevaluations are often requested because you need to have updated information in order to maintain accommodations. Things like if you needed extra time on tests, or if you needed to take a test in a different room, if you want to have that continuing on throughout your education or into your life, you usually have to have updated testing to be able to prove that you need that when you apply for those accommodations. Maybe you had them in high school, you need them in college, et cetera, et cetera.
Is there a number of years that you've heard of, like as a rule of thumb?
2 years. Having testing done within 2 years of the application is usually
really
the standard.
2 years.
Yeah.
Okay.
Yeah. And
I would have thought 5, but
yeah, no, 2 years is usually pretty consistent that I've seen. And I mostly test people for accommodations when they're going to college or standardized tests. So they tend to be a little bit more strict than other things. But sometimes people don't need them. College is actually getting much more lenient, I guess. You don't have to apply. You don't have to show testing as much anymore. It's much more rigorous, obviously, on like standardized tests, like for like the GMAT, the LSAT, stuff like that. Or then if you're going into grad school, they're a little bit more stringent.
Yeah. Okay. So I made a list of some things that came to mind. And the first one was, how long has it been? And I mean, how do you think people should think about it? Like going into that, if it's simply a re-eval because a number of years have gone by or because a new kind of application is coming up, how do you think you should mentally approach it? Because I'm just remembering from the notorious ADHD article in New York Times Magazine about how symptoms don't necessarily, like symptoms by definition don't stay stable forever.
Nope. I've run into this where people come back for testing for accommodations and the testing results don't match what the testing results were when they were a kid. If they're an adult, sometimes it's they've done what they need to do. They've taken the medications, or they've made changes to their routines, or they've learned certain coping skills that when I test them, there's no results that are suggesting that ADHD is present. And that can be really jarring because accommodations sometimes have been part of that routine of that, hey, this is how I am successful. This is how I can cope with this. But if I don't have evidence in the recent testing, it's not me saying yes or no. Like I can point that out of like, hey, sometimes they've just developed out of them, or, you know, they've grown to be able to cope with it effectively, so it's not showing up on these results. But the people who are deciding if you need accommodations, like if they're not seeing it on the test results, they might say no, you know? So
I think we're testing, even just like in class, you know, testing or whatever. I think where that's concerned, I think that a wise approach is kind of like to double cover, you know, yourself or your child. And by that, I mean, like, do test prep work, like test strategies, you know, how do you approach the test? How do you narrow down multiple choice options? Test anxiety management can be helpful. I think doing all of that, even if, you know, you're getting a separate room or you're getting extra time or whatever, just because you don't know if that's not going to be there forever.
Yeah, you definitely can't rely on that. And the higher you go up, the more stringent the requirements are. And it's tough because if you don't have a history of it, it's hard to prove that. And even if you do have a history, it's just, you know, there's a lot more qualifications, or they're just more stringent about offering accommodations at higher levels. And I do think it is helpful to think about, if that's not there, how do I go through grad school? How do I get through this standardized test? You know, really practicing those skills.
Yeah, those skills can be so helpful, and probably helpful even if the accommodation is there. 'Cause the accommodation is meant to bring, you know, to try to eliminate sort of an unfair disadvantage, but it's not supposed to be an advantage. It's not supposed to, you know, help you narrow down your multiple choice options. So my next question was the eval thorough?
Yes. I was thinking about that when we were broaching this topic of like, what was the previous evaluation like? And that is so subjective that there are times, I think in general as a field, we can be pretty judgmental of each other.
Oh, we're vicious to each other.
We're vicious to each other.
Yep.
So we're always going to take a look at the previous evaluation, and even though we shouldn't, we're automatically assuming the worst. We're very harsh critics.
I don't know why we do that.
I don't know. I don't know. I think it's because we're nervous.
Yeah.
We're nervous that somebody knows more than we do, or, you know, we're nervous we're just nervous.
Yeah, well, none of us want to find out we've been doing it wrong.
Yep.
You know, so we're always kind of on this like offensive defense, but like, does that make any sense? Like, you know, we kind of like go claws forward just so that, because, you know, what if I find out that the guy down the street doing testing is like doing a better battery than I am, or doing it differently, and what does that mean about mine? Anyways, but
I think if
was it thorough?
I think if we were to describe what thorough means, or like what a good evaluation maybe means, I was thinking about, you know, maybe that it's got multiple tests, right? We don't really want conclusions to be made off of one test. And I think that when you're reading through the report, it's a fine line of walking as the report writer. You want to be thorough and explain everything so that people can piece it together. Okay, this test result means this based on this information you said. This is how I came to the conclusion. But we as writers often are stuck in dissertation mode and writing for our supervisors, and we write too much, and it makes it hard for our clients to really digest. So I think that when you're reading through that report, hopefully there is some kind of general conclusion. A plus B equals C. And there's like a clear justification based on the results that's like, okay, I can see how you've gotten to that conclusion. I would say if those pieces aren't there, then I would say your report's not thorough.
I agree with that, you know, because it's interesting because I don't give as many tests as some people do. I'm of the opinion that sometimes we're giving too many tests unnecessarily. I know some of our peers would get mad at me for saying that, but that's my opinion. That's fine. It's really, to me, a matter of like, was the question thoroughly investigated? Not like, did you do 100 tests or only 10? But then my next one that I wrote down on my list was, did the conclusions seem to make sense? And
that's a good question. Yep.
Well, right. I mean, I sort of mean it on two levels. Like, does it ring true to what you know of yourself or what you know of your child. It shouldn't be like an answer from left field that's completely blindsiding. But I also think that, even with the jargon that we see in reports, you should be able to read what the person has painstakingly written and somehow see how they're, the way they're interpreting the scores gets you to some sort of label and recommendations.
Yep. Yeah, I don't think there's any magic number of tests, magic pages, numbers. Is it answering the question? Now, I think you do bring up a good point, though, of does it seem to make sense? So what happens when somebody comes in and they're convinced their child has ADHD and the tests show that they don't? How would somebody maybe decide if it's thorough or kind of matches that, like, hey, it's not surprising? Like, what are some characteristics that a report would have that still seems to be thorough and answers the question, even if it's different than what you thought?
Well, I guess knowing what I know about testing reports, like there should probably be a blend of some data, which can only take you so far. As we were saying, there is no objective test, but we can gather data on different things. So especially in testing children, some of the data will be observer scores. Mm-hmm. And then those are what's called normed. So, depending on how you answer, it's compared against these samples that they've done in developing the tests of like thousands of people. So it's not just that, you said yes 5 times. What does 5 mean? It's more like, no, how many people also say yes 5 times? Mm-hmm. And so if most people say yes 5 times, then it's like, well, then that doesn't really tell us much. That's sort of everybody does that sort of thing. Versus your number of yeses is unusual compared to the sample of people that we normed this on. So that's some of the data that we can get. And so that should be explained. Mm-hmm. And then we combine that sort of data and, it might be performance, like how many of, we gave you a bunch of numbers to remember and then we gave you a bunch of things to do backwards and, standing on your head, not really. Some of it might be performance, but then we blend it with, here are the things I saw testing this individual. And then here are the things that are being reported as happening at home. Here are the things being reported as happening at school. And so that it should blend all together. And so if you start seeing, like, I've seen reports where it's like, observations where there was no inattention and no hyperactivity. And here the teacher says that, this child is bright and is not inattentive in the classroom and, is completing their work and whatever. And then I get to the end and it says inattentive type ADHD. And I'm like, I don't get it.
Yeah.
I literally can't connect the dots because I thought you had told me a bunch of times that you didn't see inattention. So then if you're going to say this is clinically significant inattention, show me how you got there.
Yeah. 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 So I think that for people, if you're like reading a report or you get your child assessed and maybe the answer is different than what you experience, I think you can tell if the report is thorough, like you're saying, with do all the pieces make sense? Like, okay, we've this piece, okay, I can see how you got to that conclusion. That's different than what my experience is, but you explained to me, okay, the teacher didn't see it, I didn't see it, so there's maybe this one spot that it's happening. That means it's something different because it brings it back to the criteria of ADHD has to be seen across multiple places. Okay, so it's like, as long as there's a lot of there's data, it's supported, it's understandable that it got to that conclusion, even if it's different than what you thought, I think is still a sign then of a thorough report.
Yes. Yeah, I think that's exactly it. Like the psychologist is in a lot of ways trying to show their work.
Yes.
So, let's look and see what work they're showing. And it's the same thing with other stuff too. If you end up with a label related to anxiety, then we should have seen mentions of that or hints of that at other places. It should all kind of like connect through.
Yeah.
And it's okay. That's, one psychologist's way of interpreting the data that they got. But at least it should be consistent,
Yeah.
Throughout. And if it isn't, it's really helpful for psychologists to include, like, yes, there were all these normative scores, but here's why I'm kind of overriding that and saying that it's clinically significant, even though I got a bunch of normal scores, which I probably wouldn't do that. But
yeah.
I also wrote, did your loved ones understand the conclusions? Like, did the people around the individual, did they feel like it?
Yeah. Yeah. If it maybe really shocked you, but maybe your spouse was like, yeah, no, that's hitting the nail on the head. And then maybe your mom was like, yeah, no, that tracks. I think that's really helpful because it's hard to digest a lot of this information that you get from that. I think we've talked about before that a feedback session is so hard because in an hour, you have to tell somebody so much about themselves, something that in a therapeutic context might take a year of weekly therapy to be like, okay, I'm going to give you this piece. I'm going to give you this piece. I'm going to give you this piece. Does that seem to make sense? Okay, what are your thoughts on that? Like,
unfold,
process, digest, think critically about it. And we have to deliver all of that in 1 hour.
Or, I know some people maybe take longer than that, but like still, it's not an ongoing relationship. So you have to tell somebody about themselves. It's a tall order.
It is a tall order.
I wrote, was it a mild case of something? So even if they come out with, that could be anything. Like if they come out with major depressive disorder mild, then it might be worth getting reevaluated, or even just asking, like, if, you see somebody regularly, like a therapist, just sort of saying, do you think this still applies?
Yeah.
Because that means that it sort of popped its head above the level of significance, but there's nothing to say that these things are not permanent. Usually, I think there are some exceptions, like autism is, that's not gonna. Now the functional impairments might go up and down. There might be, if it's a mild case of autism spectrum disorder, there might be times when it's more impairing and times when it's less so.
Yeah.
ADHD now, we're calling into question whether or not this is a lifelong permanent label. And we're saying that the research shows some fluctuation of symptoms and impairment, such that there would be times when people diagnosed drop below that threshold and no longer meet the criteria. So if it's ADHD mild, I would say don't assume that it's just there forever.
Yep. Yeah. No, I think that's a really important point to bring up, is that there will be changes to it. And, like if you think about it, and if you got diagnosed with ADHD after some testing as a freshman in high school, and then you go, work in a context where that school environment is really different and you're on your own, and like there could be so many things about life after high school that are much more conducive, that the impairment's not there, that it's okay. So
I know there's kind of a climate right now where people feel like that is really injurious to suggest that something could get better or just sort of abate on its own. I know that feels terrible to a lot of people. I think it must be a factor of it was hard to come to terms with it the first time. And so my guess is that we just underestimate our ability to come to terms with it again. The sort of like, well, now I have to make another adjustment. The first time it was hard. I had to admit things about myself that were painful to admit. I had to come face to face with like my weaknesses and limitations, and that was really hard. And so I did that. I don't ever want to go through that again. I guess if it were my family member, if it were my client, I would sort of say, like, don't sell yourself short to receive news that your symptoms have gotten progressively better. There's been some improvement. The functional impairment has reduced. That I guess I would say, is it possible to, like, are you selling yourself short that you couldn't adjust to that again?
Yeah. No, I think that there's definitely a theme in mental health of emphasizing broken, and some of that comes from and some of that can be very validating, right? Where it's like, hey, this is hard, this is a problem, because I think before it would easily be lumped under, oh, well, you're just anxious, like really invalidating. So it's like, okay, we want to see the impairment. We want that to be validated and acknowledged. And I think we've kind of overcorrected on that side, where then we emphasize the brokenness. And I've seen kind of a shift in clients really appreciating when I don't do that, really emphasizing you're not broken, you are capable, all of those things, and really appreciating, like, I just appreciate that you never made me feel like I was broken. And it's like,
Aww.
That's great. Like, I'm glad that's coming through, because it's a fine line to acknowledge the pain and the struggle and also have hope. You know, where it's like hope can be just as validating. It may not feel, it's timing, I think, is important, right? When you're validating a struggle, we don't want to rush in with hope sometimes. We got to maybe sit with that. But I think that being able to introduce that is really important. And I hope we're trending in that way.
I know. I do agree with you on the overcorrection. And I feel like I can hear always the exceptions in my head. So for example, if you have experienced a manic episode and you've been told you have bipolar 1 and you need to be on medications. Okay, yeah, there's a place for that. Is kind of the task of the moment, is to come to terms with that as a reality. And for many people with bipolar 1, it can be very dangerous to come off of those medications because manic episodes can be really, really scary and dangerous. And there can be an element of the person not realizing that they're in trouble.
Yep.
And so, okay, so there's an exception where there might be a case for, let's call this permanent. Let's come to terms with it and not sort of undo that, because that could sort of be a sign of losing insight into what's there. But then do we over apply that, you know, to lots of conditions that actually ebb and flow and that, you know, may not be inherently dangerous.
Right. Yeah.
Yeah, how do we do something in the middle? Like you said, like, could you accept that there might be this thing about you and not be broken?
Yeah.
I don't know. What do you think?
I mean, I think there's an element of it right now where the brokenness is really, it's two things. I think there's a community element. I think there's kind of a, like, I feel seen. I feel like I have a community of people that can relate in this way, and we struggle this way. And it's not necessarily the brokenness that they're bonding over, but it's just the sense of community, feeling seen, feeling validated. But it's very loud right now. I do think that mental health it's had different, people have had different opinions about mental health. And I think at times people have had to be really loud about their struggles in order for people to see it and recognize it. And so I think that has, I think that's where there's a tendency for it to be one-sided or one-dimensional, you know, where you're like focusing on this piece of broken, but trying to hold both is hard, because it's like, well, is somebody going to see me and see my struggle if I tell them I'm okay?
Yeah, I mean, that's something that comes up around like therapy termination, or I used to see it when I worked in a hospital, that when we would get close to discharge, symptoms would actually flare up.
Oh, for sure.
You know, and there's there's a logic to that, because it's sort of like, well, if I get better, am I then out on my own? All of a sudden the expectations feel too high.
Yep.
You know, so like it's almost like there's this unconscious kind of like no, I can't handle that. I'm going to show you that I still need you.
Yes.
And so I really think like some of the incentive structures there are really complicated, because you're absolutely right about the community aspect. So the idea that like, oh, well, I happen to just be in a phase right now where like I was previously told I had ADHD, and now for whatever reason, you know, things have gotten a little better for me. I'm in a real groove. Maybe I found a job that really suits my tendencies.
Yeah.
And now, do I no longer get to be part of
that community
club? Yeah. I can really understand why that wouldn't be wanted. And at the same time, we know that, you know, like the more we attach kind of identity. This is sort of like, I don't know, I feel like I'm going to get Buddhist here for a second, but
no,
like,
it's okay.
That kind of like attachment to identity and making a label yourself is inherently a really vulnerable position to be in.
Yes.
And it could, unfortunately, unconsciously, you could almost sort of like want to make things worse for yourself.
100%. Yeah, because it's almost like, how do you relate to yourself? How do you understand yourself? If you now understood yourself as a person with ADHD or somebody who is depressed, who then isn't feeling the impairment of that, well, wait, is that still a part of me? Because so much of that was an impairment, was a brokenness, was something negative. So then if that's no longer there, it's like, well, hey, that's a good sign, but who am I then if I'm not that person? And I think that extends to the connection in the community as well, of like, well, who is my people now? Like, where's my community? Community is extremely essential to us as human beings. So relating to ourselves, relating to others is really hard. And when you brought up kind of the Buddhist idea, I think there's just a real difficulty with being able to hold two different things, right? To be somebody who is depressed and be somebody who is functioning in society just fine. You know, those are two opposite ends of the spectrum. So it's a lot of space to hold. It's two competing ideas. And so it's hard. There is cognitive dissonance around that. Mm-hmm. And cognitive dissonance is extremely difficult for human beings.
Yeah, we don't like that so much. So we either change our beliefs or we change our behavior just to resolve it. We cannot handle that in between.
It's very hard. You know, the idea of accepting multiple ways of being or just a range of human experiences is very difficult.
Yup, I completely agree. So I had on my list, get reevaluated if your circumstances have changed in a major way. So I think we kind of talked about that. I said maybe you should get reevaluated if you've tried the interventions that were suggested, like if you've really done the things that were recommended and then did it work or not. Mm-hmm. Because that could be a clue as to whether or not the conclusions were right. Would you agree with that?
I would say so. Yeah. I think you'd have to assess like what we were just talking about of like, did they work? You know, like, did I try them and they worked and now I'm not feeling any I feel like I don't need them anymore. It's not saying that they didn't work. It's like they actually did work, but I don't need them as often. Does that make sense?
Yeah, I guess I wouldn't. Maybe I wouldn't necessarily imagine someone going through the expense and the time to get reevaluated if the interventions worked.
Right. Yeah.
Maybe that's just like a topic for a therapy session, or just talk to your, spouse about that.
Yeah.
But yeah, I mean, I think if you've really given an honest try to everything that was suggested and it did not work.
Yeah.
Still, there's always that little caveat, because we are influencing our, we're co-influencing this. Like, even like, how do I know if I really gave it a try? Was
100%.
Was I secretly hoping it wouldn't work?
Yeah.
Right. So,
yep.
But still. And then the only other one I came up with was maybe get like a second opinion or a reevaluation. It said, I wrote, does it seem like the clinician has only one niche? So does, upon further research, does it sort of seem like this psychologist
always says you have ADHD?
Uh-huh.
Yeah. How would a client know that? I mean, obviously we would see that, but
I don't know.
That's a good question.
I mean, it would probably come through maybe in some marketing, or maybe it's their social media page.
Yeah.
Or maybe you're in a community where a lot of people go to the same person.
I was just gonna say that.
If it sort of seems like the same answer is coming out of the same place.
Yeah.
I wonder if people feel like they have permission to then to have critical thinking around that. You know, I wonder if there could be this feeling like, well, who am I to question? You know, they went to school for a long time. They have, you know, degrees and thriving practices and millions of people who go see them, and like they must know. So how, like, who am I to question it?
Yeah, I mean, I think you would question that with any doctor, right? Or any provider. Like if I'm going to, I mean, going back to cancer, because that's a little more concrete, if they're always diagnosing the same cancer with every single person, like I think when any of that rate of positive diagnosis is, you know, super high, like you got to question that, you know. I think it's always something that needs to be, like really every time?
I wonder, do you think that's ever happened?
Well, I'm pretty sure these are, you know, cherry-picked examples, but I think that was like one of the Dr. Death episodes, or one of the things that they were always, like it was, they were always seeing this one particular condition because they were making a lot of money off of that, or they were really like, there was, I'm pretty sure that was one. And I think that that's been, you know, you can see like true crime podcasts or things like that where like there's those conclusions, but yeah.
Oh my God, you're exactly right. And I'm thinking now there's a case here in Illinois. There's a doctor who I think she was sentenced to jail time.
Yeah.
I think she was an OBGYN, and she was there, like, these are extreme newsworthy examples, but yeah, I think she was diagnosing like the same condition. People were getting diagnosed with something they didn't have.
Yeah.
And then do you know what I'm talking about?
Yes. And it was very similar to I think it was the third season of Dr. Death, that they were always diagnosing this particular kind of cancer and giving people treatment for it. And it was making them so sick. Like it was,
oh my God, that's real messed up. That is extreme.
Extreme, okay, meaning like not happening often.
That's not quite what we're saying here. Interesting to talk about, but like that's not quite it. I think in mental health, it more, because none of this is objective, so it's really hard to go figure out, like, we always kind of have to put truth in quotes. What is the truth about what disorder you have, like, according to who?
Yeah.
You know, but like if you name your clinic after a disorder, like then it could be that, you know, you're more likely to find that disorder than someone else would be. And so our lens influences what we say about the people we're seeing. And, you know, ideally, ethically, we're supposed to examine our biases.
Yes.
We're supposed to examine our incentive structures.
Yep.
You know, and put the patient, the client first, put their well-being front and center. But that's not to say that always happens.
And not to confuse well-being with happiness, or like if they feel like they had a good experience, because sometimes putting their well-being first is to say no, you know, and that's really tough, I think, to navigate. To
say no, or to say the thing that they might not, you can tell they don't want to hear. Well, it could be the opposite too, but you know, totally. We can feel maybe what answer people are hoping for. And trying to stay as objective as we can is hard. What were you going to say?
I think the other thing I would say with the reevaluation is to be aware of time frame, that there are certain tests that can't be given in a certain time frame, like for risking like practice effects. So you might have to wait a certain amount of time before you get reevaluated. So just being aware of that, like if you are going to decide you want to get reevaluated, you know, right away, you know, say you got an evaluation done, the results were this, and 6 months later you want a second opinion, just be, you know, aware of that maybe some people won't test you. They shouldn't, you know, they should say, hey, you just had these done, I can't do some of these tests again.
Yeah, practice effects, meaning like because you've already been exposed to the questions in the testing,
you're familiar with the process, and that could skew the results in a different way. So
it's just logical when you think about it.
Yeah, and there's a standard of that, so you have to be aware of that if you do want to get reevaluated, sometimes you can't in a certain time frame.
I think that's why I was surprised to hear that a lot of these like high stakes accommodation situations want 2 years, because like, what if you did it 2 years and a day ago?
Yes,
and now you're applying. I mean, I think a lot of these you could get away with like a 2-year gap, and it probably wouldn't be the end of the world as far as practice effects. But like, this seems a little quick.
It is quick, and I think that there's a lot of nuances of how it actually gets practiced. I don't think people are needing to get reevaluated every 2 years, because like, say you had accommodations in high school, but you don't want them in college, or maybe you don't get them. You try to just see what it's like, so it's then maybe you go on and you want to take the LSAT and you want to go to law school, and then you want to, I think I need those accommodations. I was in college. It wasn't as great as I thought. I didn't get the accommodations. I kind of struggled. I think I want them there. So like, that's how it actually kind of plays out. Usually people aren't actually getting reevaluated every time they need new accommodations. What was the other piece? Oh, and I've ran into that where people have been reevaluated too soon to use a certain measure. So say I need to use the WACE, and they had it done maybe 2 years ago or something like that, I will use a different test. So I'll try to get to the same conclusion with a different test and talk about that. And so there's ways around that, but you have to think about that.
You do. And, I guess another option within this is like a second opinion.
Yeah.
Which isn't exactly a reevaluation. But if your spidey sense goes off as far as any of these things that we were talking about, like I can't see how they reached this conclusion, or it didn't seem very in depth, or it didn't seem thorough, or, I'm having this weird spidey sense about like the clinic where it was done. You can take the same scores and have a different person look at the same scores, and they might do their own interview, which they probably should do a thorough interview with you, and then kind of add in the scores that you just got and start putting it together their own way, and you can see if they come to a similar conclusion or not. Yeah, I mean, I would happily do that for somebody. I'm assuming our peers would.
Yeah, I would just put some caveats in the report, just because obviously I'm not the one doing the test, so I didn't know how they did it. It depends on how much data I actually got. If I got the actual raw data versus just like the scaled scores, I'd just put a caveat in that in my report and in my explanation to the client if I don't have 100% of all the pieces. And I'd keep that in mind when I'm doing my own interpretation, like. I think that the other piece I want is I hope that as a field, that if somebody comes to us for a reevaluation and we agree with the conclusions that were given, say so, don't feel pressure to change your mind if that's not there. If there's consistency that needs to be made, then please do it.
Yeah. And I mean, that could be worth it if you're having a strong reaction to the results that you got, if only because, even if a second opinion concurs with the first opinion, they're going to say it in their own way. And maybe there's a way they can say it that makes more sense to you, or kind of makes it feel more true to you. Just, I mean, like, vocabulary can mean everything when you're talking about someone else's psychology, like the way that you phrase it, the way you put it into context. And
sometimes people need that second opinion. Maybe it's just that same situation where they're saying the same thing, but okay, now I've had more time to digest it. The second person is saying that, okay, how can I hear that now differently?
Yeah. Do you have anything else on this?
No, I think that covers some general topics that we wanted to address with this idea.
Yeah.
Okay.
Got a little spicy, maybe?
I thought we were good. Mild spice. All right, folks. We'll tune in next time while we talk about another topic. And
thanks for listening. Thanks for subscribing.
See you soon. Bye.
This podcast is for informational purposes only. It is not a substitute for treatment of any kind.